approach of one of the very common disease. We have seen many of these retinal diseases which are not as common as diabetic retinopathy. There are some guiding principles in treating diabetic retinopathy. The first thing you do is you classify it into a sight-threatening versus non-sight-threatening. What is sight-threatening? Anything less than moderate. What is non-sight-threatening? Anything less than moderate is a non-sight-threatening. Severe NPDR, PDR, and macular edema comes under a sight-threatening diabetic retinopathy. You consider doing investigations, sometimes fundus routine angiogram, OCT, OCTA, ultrasound, wide field imaging, whichever is needed. And for proliferative disease, PRP is a mainstay of treatment. You classify diabetic macular edema into a center involving or a non-center involving diabetic macular edema. Again, glycemic control, the control of BP, lipids, anemia, they are very crucial. And anti-VEGFs are still the first line of treatment in center involving diabetic macular edema. You can switch anti-VEGFs, switch to laser, switch to steroids if it is a non-responder or a poor responder diabetic macular edema. OCT and vision are the key tests to determine the initial treatment choice, and also you want to see how the response of the treatment is coming. So on follow-up, these two are important. And in case where there is vitreomacular traction, in select cases of non-responding DME, you also have a role of vitrectomy. So these are certain guiding principles whenever you are thinking of managing diabetic retinopathy. Let's talk about two sight-threatening conditions, DME and proliferative disease. So if it is a DME, you first see whether it is center involving or not. So if there is more thickness in the central subfield, so you can define center involving by two ways. One is based on thickness, one is based on lesions. So if you get more of cystic fluid or any of the diabetic lesions, retinopathy lesion in the central subfield of your OCT, you can call it as a center involving DME. Now, how to treat it? So you can see this non-center involving DME. It can be a treatment nevi, or it can be even after injection. So patient was already on injection, comes to you, and you have the central edema is not there, but paracentral edema is there. You look into vision. Anything good vision you tend to observe. Laser is still a mainstay as far as non-center involving edema is concerned. Very recently we have published that we followed these non-center involving for 2 years. A third of them, nearly 26% of them, convert to a center involving in 2 years. And the only risk factor is longer duration of diabetes. So if you have people with longer duration of diabetes, be more watchful for this conversion. If it is center involving, you look into vision. Anything good vision, 6/9 or better. Protocol V of DRCR-net taught us that no need to treat them, you can observe. And if it is worse, anti-VEGF injections can be started, intravitreal injections. Usually we continue for about 3 months and then determine whether it is a good responder or an intermediate response or a poor responder. So this again depending on the anatomical response and the visual response, you take a call. Good responder, you can continue anti-VEGF. It's a partial responder, you can still consider continuing. If it is poor responder, you can switch to another agent, or you can think of using a steroid. How to determine which one to do? There are certain patient-related factors you can take into account. So if a person had a recent history of cerebrovascular accident less than 3 months old, you avoid using anti-VEGFs. You can consider steroids. You can also consider laser. If it is a pregnancy DME, you see in pregnancy, mild edema, you can still watch with a good vision. If vision is poor early in the pregnancy, laser or steroid can be considered. Late in the pregnancy, if you get a center involving edema with a poor vision, no need to treat. After the delivery, the edema will automatically reduce. So poor compliance, again, these are the cases you can think of giving a little longer acting newer anti-VEGFs or probably steroid. If a person is of a chronic kidney disease, many times we do have these patients. You start with anti-VEGF and during treatment do monitor that how his eGFR is. If it is worsening, you can give a break and then continue again. There are also some eye-related factors which govern what agents to use for DME. So if you have a vitrectomized eye, you know that the vitreous sump is not there. These are the cases. If it's an early edema, you can still watch. If it is late, steroids probably do better in terms of less number of injections. Equal anatomical results have been shown with anti-VEGFs too. However, they need much more injections as compared to steroids. If it is diabetic macular edema with proliferative disease, anti-VEGF is the first choice. You can do PRP or you can even do a deferred PRP, meaning that you give a anti-VEGF and then followed about a couple of weeks later completing your PRP. If it's a pseudophakic eye with DME, important to differentiate whether you're dealing with a pseudophakic or diabetic or they have both the components. Both have to be tackled together. You can consider steroids in these cases as an initial choice too. There are some disease-related factors. So we had patient-related, eye-related. There are some disease-related, like you have plaque of exudates. Again, important to control dyslipidemia. Intravitreal steroids have shown that they reduce it much more quickly. However, vision-wise, you have to be guarded because even if they resolve, they cause an area of atrophy. A poor vision or a thicker retina, you can consider the newer drugs, Eylea or faricimab, and even intravitreal ranibizumab works well. If there are vitreoretinal surface abnormalities, these are the ones you must understand. Anti-VEGF still can work, but they need more injections. You can consider steroid, and if it is not responding, vitrectomy is the choice. And then you start assessing the response, and if there is a poor systemic control, if it's a poor responder, definitely look for poor systemic control and do appropriate referral. It's good to identify the best response from the history because many times they say initial injections worked well. Try to consider the same drug when you're switching. And if it's a chronic edema more than 6 months, again, not responding, steroids can be considered. And again, if there is some drug history, there are a couple of these drugs which can cause diabetic macular, which can cause macular edema. And if they are on these drugs, definitely you want to stop it, and that will help resolution of the macular edema. So this is the algorithm. I'm not going in detail, but exactly what I spoke is covered in this small algorithm. Coming to managing proliferative disease, again, as I told you, panretinal photocoagulation is the mainstay of treatment. However, in certain situations, you can change. If you have diabetic retinopathy with a single NVE, good compliant patient, you can consider monotherapy with anti-VEGF2. However, if it's a poor compliance, definitely go ahead with PRP. If there is no traction and the patient is again a good compliance patient, you can consider anti-VEGF and later on do a PRP. If there is traction not involving fovea, you tend to do a panretinal photocoagulation about 2 disc diameter away from the areas of TRD, otherwise you will convert it to a combined retinal detachment. If it is with center involving DME, you do anti-VEGF with PRP. If it's active PDR, even despite your complete panretinal photocoagulation, you assess the size of the vessel, whether they are mature vessels or still immature vessels. Mature vessels, you can wait. If it is immature vessel, you go ahead doing a supplemental PRP. And if there is PDR with NVI, you need to really be very aggressive. Don't wait for a PRP response of 3 months. Call again after 2 weeks. You want to do a more aggressive PRP as compared to a normal PDR. So the success of treatment in diabetic retinopathy is not just anti-VEGF, not just steroids, but a very good control of systemic factors. Most important is a good compliance to follow up and a good compliance to treatment. And you must understand the patient's journey. It's not getting over, it's a lifelong journey. He has to be with you. Thank you very much. I would like to invite all of you for the 6th Retina Summit and IROP meeting.